Thanks very much for this opportunity. I need to uh, talk to you about my thoughts on the definition of severe aortic valve stenosis, and there's some disclosure for my talks. And this is everybody knows the current guideline recommendation for aortic valve replacement, heavily basis on the symptomatic stage of aortic valve stenosis. But in patients with the asymptomatic stage, ejection fraction of less than 50%, either cardiac surgical procedures or severe AS with the valve area, the velocity of more than 5 meters per second, and then mean gradient of 60. Those are classified as a 2A recommendations, right? But I think we need to revise the current recommendation of ABR or the definition of severe aortic valve stenosis. My definition of aortic valve stenosis is any condition of AS that benefit from the aortic valve replacement. May not be severe AS by the aortic valve gradients or valve areas or velocity, but I think there's a lot of data now that the moderate AS currently defined may benefit from the aortic valve replacements also. So let me just go through a few items. I think the current guideline uses the ejection fraction cutoff of 50%, but this is a data that we put together a few years ago that in patients, you can see in 2 years, valve area went from 1.2 to 0.9 square centimeters, and ejection fraction went from about 60% to 25%. And then we are curious why this happens, really. Is that all afterload problems or severity of AS? But when you look at the patients with the reduced EF at the time of severe AS compared to the patients with a preserved ejection fraction at the time of severe AS, there's a time zero. And we went back about 10 years of the echocardiogram and then plotted their progression of ejection fraction as well as other hemodynamic and valve characteristics. And you can see that in patients with reduced EF or preserved ejection fraction, their progression of aortic valve area reduction here is about the same. But in patients with a reduced ejection fraction at the time of severe AS, even 10 years earlier to the severity of AS, here the ejection fraction is 52, 53% on average. Compared to the patients with a preserved ejection fraction, the ejection fraction of 65%. So I think they do have some intrinsic cardiomyopathy process that accompanies the severe AS, and then that is mainly responsible, in addition to the pressure overload, to reduce the ejection fraction of the patients with a severe AS. So when you look at their cumulative survival of those patients based on ejection fraction, actually the patients with the EF 50 to 59% here is much worse than the patients with ejection fraction 60% or greater. So we feel that the EF cutoff should be up to about 60% rather than 50%, and then the other area of revised definition is a gender difference, right? Because when you look at the men and women, and this is work of Dr. Ito and Dr. Miranda of our institution, that when you go back again 10 years of echocardiography of patients with a severe AS, and men and women come down together here at the valve area of 1.2 square centimeters, this is when the valve area precipitously goes down. And then also the peak velocity and mean gradient goes up much quicker at about 1 or 2 years earlier than the severe AS. And also that the peak velocity and the mean gradient is much lower in women than the men because of the smaller stroke volume and the smaller cardiac chamber size. As you see it here, the LV dimensions are smaller and then stroke volume is lower. So there was a given aortic valve area that the mean gradient is much lower in women than men, although we are using the same velocity and the gradient and the LVEF for the severity of aortic valve stenosis. So I think that we really need to have some differential criteria for defining the severe aortic valve stenosis. And then we also need to assess the underlying myocardial disease, because if you look at these three patients with severe AS with sort of similar severity in terms of their peak velocity and mean gradient from 4.1 to 4.5 meter per second, you can see that the systolic function by strain imaging is quite different from normal to really severely reduced. And also the diastolic function is normal to significantly reduced with the restricted filling. So we really need to use all the data available to us, in addition to the hemodynamic data of the valve, of the gradients and valve area, to determine the severity and also the timing of the aortic valve replacement. And this is the most recent data actually from Seoul National University, that international study that arranged by the Seoul National University, showing that when you look at the moderate AS patients here with the blue, and then green is asymptomatic severe AS, that the older valve area is quite different, right? Because of the different severity of AS. The fibrosis degree of the extracellular volume fractions are almost identical between the moderate and severe aortic valve stenosis. And then also filling pressure is a little different, but quite close, much closer than the difference in the aortic valve area in this particular patient population. So when you look at their mortality of patients with moderate AS or asymptomatic severe aortic valve stenosis, really all based on the underlying myocardial fibrosis. This is based on the cardiac MRI findings, and mean value around 25 to 30%, and you can see that significantly worse the clinical outcome in patients with a much higher degree of the myocardial fibrosis determined by the extracellular volume fractions, as you see there. And this is the data we have shown that the about 700 patients with a moderate AS, that we have a 40% mortality in 3.4 years, almost similar to the severe AS, and then much higher mortality with low EF, low stroke volume, low global longitudinal strain, and high filling pressures, and also the high NT-proBNP, as you see here. And this is a data from Australia also showing that the much worse prognosis in the high filling pressure determined by E/V prime ratio, regardless of the underlying ejection fractions, as it's here. So I think the filling pressure estimate is very important in prognosticating and also identifying patients at risk of a bad outcome in aortic valve stenosis. And this is actually data from Dr. Park Po-won and Lee Young-tak. And when they were in Samsung Medical Center, that they put together the data that the patients with aortic valve stenosis, when they underwent aortic valve replacement, right, and the high filling pressure has much higher in-hospital cardiovascular complication, and also long-term outcome was much worse even after the aortic valve replacement. So I think even the pre-operative diastolic function and filling pressure assessment is very, very important for identifying the patients with increased risk. And then this is the patients that we look at the Mayo Clinic, same data, but the larger number of patients showing again that the increased filling pressure determined by the E/V prime ratio has a very, very prognostic in patients with severe aortic valve stenosis. This is the data we put together in patients with the moderate AS, 287 patients. When you look at their global longitudinal strain, the mean value was about 15.2%, and there are significant difference between the two different GLS values, and that difference of the clinical outcome is much attenuated by the aortic valve replacement. And finally, I just want to say a few words. I know Sejong Hospital has been very dedicated and has a lot of pioneering work with electrocardiography AI, and we have done similar work. And this is work of Dr. Lee, and who is our AI engineer that put together the electrocardiography AI for determining LV systolic and diastolic function and filling pressures. And this is the AUC she was able to obtain with the AI ECG for determining the high filling pressure versus low filling pressure, and also different types of the diastolic filling patterns, as you see it here. And then grade 2 or 3 are the ones that increase filling pressures. And when they use that AI-enabled electrocardiography diastolic function, the prognosis clinical outcome is quite distinct. You can see the normal, and then grade 1, and then high filling pressure with the grade 2 and 3, and which is comparable to what echocardiography can do here in the overall patient populations. And when we look at that, patients apply that AI ECG diastolic function grading for prognosis of patients with AS, whether moderate AS or severe aortic valve stenosis, is pretty significant here with normal to grade 1 with normal filling pressures. And then this is patients with grade 2 and grade 3 with a significant increased filling pressures in the similar in patients with severe aortic valve stenosis. And again, this is a patient that who presented to us with a cardiac arrest with a really significant severe aortic valve stenosis, that who didn't know the patient had the aortic valve stenosis, but the electrocardiography shows the high probability of AS, that which was not present many years earlier, and there's no electrocardiography between 2015 and 2024 when patient presented to us. So in summary, I believe, we all know that the AS, aortic valve replacement is a treatment, but I think any aortic stenosis condition that can be benefited by aortic valve replacement by the multiple factors should be defined as a severe aortic valve stenosis. And also we have to really look at different cutoff values based on gender, and then their different stroke volumes. And then underlying myocardial dysfunction is really a major component of AS that we have to really assess that with the ELVA prime, myocardial fibrosis with a cardiac MRI, and then longitudinal strain. And then we also feel that the AI ECG can be a quite promising tool for detection and prognosis of the patients with aortic valve stenosis. Thank you very much for listening.